Now let's start with chapter 42 of your Essentials of Microbiology by Apurba Sastry. In this chapter, we'll be previewing cholera, halophilic vibrio infection, and aeromonas infections. Vibrio. Vibrios are gram-negative bacilli, curved, that are actively motile by means of single polar flagellum. The name Vibrio is derived from its characteristic vibratory motility. Robert Koch isolated the organism in 1886, named it as coma bacillus due to its characteristic curved or comma-shaped appearance. Habitat. Vibrios are ubiquitous, found worldwide, being salt-loving. The natural habitat of Vibrio is the marine environment, sea and water and seafoods. Surface water, river and sewage. Among the several species of Vibrio infecting man, the most important is Vibrio cholerae that causes a devastating acute diarrheal disease cholera and has been responsible for several global pandemics and several epidemics over the past 2 centuries. Cholera. Classification of Vibrios based on salt requirement. A unique property exhibited by all Vibrios is the growth being stimulated by the presence of salt. However, the optimum salt concentration required varies among different vibrios. Accordingly, they are classified into non-halophilic vibrios and halophilic vibrios. Non-halophilic vibrios can grow without salt, but 1% salt is optimum for their growth. They cannot grow at higher salt concentrations. Examples include Vibrio cholerae and Vibrio mimicus. Halophilic vibrios, they cannot grow in the absence of salt. They can tolerate and grow at high salt concentration of up to 7 to 10%. Examples include Vibrio parahemolyticus, Vibrio alginolyticus, and Vibrio vulnificus. Gardner and Venkatraman classification. This classification of Vibrio cholerae in 1935 was based on serogrouping, biotyping, serotyping, and phase typing, which was later on updated by several researchers. Such typing schemes are of great epidemiological importance in tracking the outbreaks by finding out the relatedness between the isolates in different clinical specimens. Serogrouping. Based on somatic O antigen, Vibrio cholerae can be grouped into more than 200 serotypes or serovars, updated by the most widely used Sakazaki typing scheme, OI serogroup. O1 serogroup. Among the all serogroups, O1 was responsible for all pandemics and most of the epidemics of cholera. Strains belonging to O1 serogroup are agglutinated by O1 antisera. NAG vibrio serogroups other than O1 were not agglutinated by O1 antiserum and they were called non-agglutinable NAG vibrios. They were thought to be non-pathogenic, hence also named as non-cholera vibrios NCVs. Later on, it was observed that many other serogroups are pathogenic to man and agglutinable with their respective antisera. Hence, these terms such as NAG or NCV are no longer in use. O139 serogroup. It was identified in 1992 and since then it has caused several epidemics and outbreaks of cholera in the coastal regions of India and Bangladesh. Vibrio divided into groups, Vibrio cholerae and other Vibrio species. Vibrio cholerae divided into subgroup or serovars or serogroups like O1, O139 and O1 non-O1 oblique O139, O2 to O200. Biotypes. O1 is subdivided into biotypes classical and EITOR. And these are divided into serotypes Ogawa, Inaba, and Hikozima. So this is the Gardner and Venkatraman classification of Vibrio cholerae. Now, non-O1 or O139 serogroups, they have occasionally caused sporadic outbreaks of diarrhea and extraintestinal manifestations but have never caused epidemic cholera so far. Biotyping. Serogroup O1 has two biotypes, classical and even TOR, differentiated by various biochemical reactions and their susceptibility to polymyxin B and their bacteriophages. Classical biotype, it was responsible for the first 6 pandemics of cholera worldwide. It was highly virulent and had caused several deaths. Even TOR biotype replaced the classical biotype by 1961 and caused the 7th pandemic of cholera. It was first identified by Kotzlich 1905 at a quarantine camp on the Sinai Peninsula in Eitor, Egypt. Currently, almost all outbreaks or epidemics of cholera are due to the biotype even TOR, although occasional classical isolates are still seen. Even TOR variants. The distinction between classical and even TOR has faded over time. Many even TOR isolates of current days show properties of classical vibrios and are called as even TOR variants. or even Tor hybrids. Examples of such variants include Matlab variants and Mozambique variants. Okay. Serotyping. O1 serogroup can further be divided into three serotypes: Inaba, Ogawa, and Hikojima, based on minor antigenic differences of O antigen. Ogawa is the most common serotype isolated from the clinical samples, followed by Inaba. However, during epidemic, shifting between serotypes can take place, more common being Ogawa to Inaba shift, which occurs due to mutations in RFBT gene. Hikojima represents an unstable transitional state they where both Inaba and Ogawa antigens are expressed. Phage typing. Even Tor and classical biotypes can also be differentiated based on their susceptibility to different lytic bacteriophages. Difference between classical and even Tor Vibrio cholerae. Beta hemolysis on sheep blood agar negative in classical, positive in even Tor. Check erythrocytic agglutination, negative in classical, positive in even Tor. Polymyxin B 50 international units, susceptible classical, resistant even Tor. So 4 phase susceptibility, susceptible classical, resistant even Tor. EI Tor phase 5 susceptibility, resistant classical, susceptible even Tor. VP Vogue's prosecute test, negative classical, positive even Tor. Cholera toxic gene CTX1 in classical and CTX2 for even Tor. Now, Basu and Mukherjee phase typing was the most widely used scheme to differentiate the O1 biotypes. Okay. It was later updated by Chattopadhyay 1993, and then it has been expanded to include O139 strains Chakrabarti 2000s. Now, pathogenesis of cholera. Pathogenesis of cholera is toxin mediated. Both Vibrio cholerae O1 and O139 are capable of producing cholera toxin, thus resulting in cholera. Mode of transmission. Vibrio cholerae is transmitted by ingestion of contaminated water or food. Infective dose. Since Vibrio cholerae is extremely acid labile, a high infective dose of 10 to the power 8 bacilli is required to bypass the gastric barrier. Factors promoting transmission. These include all those conditions where gastric acidity is reduced, such as hydrochloridia, use of antacids, etc. Crossing of the protective layer of mucus in the small intestine, vibrios penetrate the mucus layer and reach near the epithelial cells, which may be achieved by its highly active motility, secreting mucinase and other proteolytic enzymes, secreting heme agglutinin protease, cholera lectin. It cleaves the mucus and fibronectin. Adhesion and colonization. The next step in the pathogenesis is the adhesion to the intestinal epithelium, which is facilitated by a special type 4 fimbria called toxin co-regulated pilus TCP. Cholera toxin, once established in the human small intestine, the organism produces a powerful enterotoxin called cholera toxin. It resembles heat labile toxin LT of E. coli in its structure and function, but it is more potent than the latter. Mechanism of action of cholera toxin. A toxin molecule consists of two peptide fragments A and B. Fragment B is the binding fragment, binds to GM1 ganglioside receptors present on the intestinal epithelium, following which A fragment is internalized. Fragment A is the active fragment, causes ADP ribosylation of G protein, upregulates the activity of adenylate cyclase, results in the intracellular accumulation of cyclic adenosine monophosphatase CAMP. Increase in cyclic AMP leads to, in small intestine, cyclic AMP inhibits the absorptive sodium transport system in the villus cells and activates the secretory chloride transport system in crypt cells, which lead to the accumulation of sodium chloride in the intestinal lumen. Water moves passively into the bowel lumen to maintain osmolarity, which leads to accumulation of isotonic fluid that results in watery diarrhea. In this image, we can see the mechanism of action of cholera toxin. Okay, cholera toxin enters the ganglioside and it enters to the G protein adenylate cyclase. It promotes the cyclic AMP formation, protein kinase formation, and which is now produced in the intestine. Loss of fluid and electrolytes leads to the shock due to profound dehydration and acidosis due to loss of bicarbonate. Gene for cholera toxin. CTX cholera toxin is phage coded, that is, it is encoded by genome of a filamentous bacteriophage CTX, which is integrated as prophage into the Vibrio cholerae chromosome. This phage genome is also encodes for TCP, accessory colonization factors, and other regulator genes. Other valence factors include zona occludens toxin. It disrupts the tight junction between the mucosal cells. Accessory colonization factors, they help in adhesion and colonization. Bacterial endotoxin, lipopolysaccharide. Unlike other gram-negative bacilli, the lipopolysaccharide of Vibrio cholerae does not contribute to the pathogenesis of cholera. However, it is immunogenic and it is included as a component or in killed vaccines. Clinical manifestations of cholera. Vibrio cholerae O1 or O139 infections produce a range of clinical manifestations such as asymptomatic infection in 75% of the cases, mild diarrhea or cholera in 20% of the cases, sudden onset of explosive and life threatening diarrhea, cholera gravis in 5% of the cases. Incubation period varies from 24 to 48 hours. The common manifestations include watery diarrhea. Cholera characteristically begins with a sudden onset of painless watery diarrhea that may quickly become voluminous. Now, this is the progression of the clinical manifestation relation to fluid loss. Fluid loss less than 5%, symptoms increase thirst. At 5 to 10%, postural hypertension, weakness, tachycardia, and decreased skin turgor occur. At more than 10%, renal failure due to acute tubular necrosis and fluid loss result in oliguria, weak or absent pulses, sunken eyes, sunken fontanelles in infant, and wrinkled washerwoman skin, somnolence, and coma. Now, other features include rice water stool. The stool is typically non-bilious, slightly cloudy and watery with mucus flakes, and a fishy, inoffensive odor. Being non-invasive, there is no associated blood or pus cells in stool. It often resembles the water in which rice has been washed. Vomiting may be present, but fever is usually short. Muscle cramps may occur due to electrolyte imbalance. Progression of clinical manifestation is directly proportional to the fluid loss, which results in loss of body weight. Epidemiology. History of pandemics. Cholera can occur in many forms: sporadic, limited outbreaks, endemic, epidemic, or pandemic. Homeland. The delta region of the Ganges and Brahmaputra in West Bengal, India, and Bangladesh was known to be the homeland of cholera since ancient times. Till early 19th century, cholera was virtually confined to its homeland, causing large epidemics periodically. First six epidemics occurred between 1817 and 1923. All were caused by classical biotypes of Vibrio cholerae, which had spread from Bengal to involve most of the world, resulted in several thousands of deaths. At the end of the sixth pandemic from 1923 to 61, cholera was largely restricted to its homeland. Seventh pandemic had started in 1961 and it differed from its first six pandemic in many ways. It was the only pandemic that originated from outside India from Indonesia, Sulawesi, formerly Celebes Island. In 1961, India was affected in 1964 and the whole world was encircled by 1991. It was the only pandemic to be caused by event Tor biotype, which had largely replaced the classical biotype by that time. Even Tor produced a much milder cholera. However, even Tor infection was associated with more carrier rate than the classical. This is due to the fact that even Tor is much hardier than the classical Vibrios and capable of surviving the environment much longer. This accounted for rapid spread of even Tor involving the entire globe, including some parts such as Central, South American countries, Australia, and other affluent countries which were never affected before. 0139, the Bengal strain. It was isolated first from Chennai in 1992 since it was not agglutinated by any of the antisera available. At the time 01 to 0138, it was designated as new serogroup 0139 or the Bengal strain as it spread rapidly among the coastal region of Bay of Bengal up to the West Bengal, then to the adjacent areas of Bangladesh. 0139 appears to be a derivative of O1 even Tor but differs from the latter in having distinct lipopolysaccharide and being capsulated. As a result, it is invasive, can cause bacteremia and extraintestinal manifestations. There is no cross protection between O1 and O139. O139 had caused large scale outbreaks of clinical cholera and spread rapidly across among all 11 Asian countries and become a threat to cause the next pandemic. However, by 1994, the fear had come down. Once again, the O1 even Tor became dominant and largely replaced by O139. Currently, O139 still causes minority of cases in India and Bangladesh. Now, current situation in the world, cholera is a notifiable disease. However, it is often underreported, hence the true incidence is unknown. WHO has estimated more than 1.3 to 4 million cases of cholera occur every year, resulting in 21,000 to 1.4 lakh deaths annually. During 2017, 12.2 lakh deaths cases were confirmed, notified to WHO, including 5,654 deaths. The number of cholera cases decreased globally by 60% in 2018, 4.9 lakh cases and 2,990 deaths. Several outbreaks have recently been reported, such as from Yemen in the year 2016 to 18, large scale outbreak with more than 6 lakh cases and 2,000 deaths reported. Nigeria in 2017, Zimbabwe 2018-19, Algeria 2018, and Somalia more than 10,500 cases in 2017 to 20. The majority of cases are due to O1E1 TOR. However, occasional cases may occur due to O139 in classical biotype, especially in Bangladesh. Ending cholera, a roadmap to 2030. In 2017, WHO launched its strategy for cholera control, which aims to reduce cholera deaths by 90% and to eliminate cholera in as many as 20 countries by 2030. In India, the situation has greatly changed in India, both geographically as well as in terms of number of cases and deaths. West Bengal is no longer the homeland. Almost all the states have been affected. Both morbidity number of cases and mortality deaths have been greatly reduced. In 2016, about 841 cholera cases were reported, in contrast to more than 176,307 cases with 86,997 deaths in 1950. In early 2020s, there was an outbreak occurred in Bangalore affecting more than 17 cases. Even though dominance continues, while O139 causes minority of cases. NICED, National Reference Center for Cholera in India, is located at the National Institute of Cholera and Enteric Disease (NICED), Kolkata. Epidemiological determinants reservoir: humans are the only reservoir of infection. There is no known animal reservoir. Source: the source of infection may be either asymptomatic cases or carriers. Asymptomatic carriers play an important role in transmitting cholera over long distances. Although carriage is usually short lived, a few individuals may excrete the organism for a prolonged period. In general, biotype even TOR has more carrier rate than classical. The case carrier ratio is 1 to 50 for classical biotype and 1 to 90 for even TOR biotype. Patients, when effectively treated, do not become carriers after they recover but can be reinfected if exposed again. Cholera season: maximum transmission is associated with high temperatures, heavy rainfall, and flooding, but cholera can occur throughout the year. Other factors that promote transmission include poor sanitation, poverty, overcrowding, and population mobility, as occurs in pilgrimages, fair, festival, and marriages. Factors determining severity of the disease include lack of pre-existing immunity. Persons with O blood group are at greater risk of severe disease if infected, while those with AB type blood group are at least risk. The reason is not clear. Malnutrition: people with low immunity, example HIV infected people. Age: during inter-epidemic period, all age groups are affected equally. However, during epidemics, it affects more number of children. Habitat: Vibrio cholerae is a natural inhabitant of coastal sea salt water and brackish estuaries, where the organism can persist for long periods, particularly in association with small crustaceans such as copepods, crabs, or planktons. Persistence of Vibrio cholerae: during epidemics, it is maintained by carriers and subclinical cases. Now, in inter-epidemic period, it is maintained in seawater, crustaceans, and planktons. Resistance: Vibrio cholerae is acid labile but stable to alkali. It is heat labile, killed within 30 minutes by heating at 56 degrees Celsius or within a few seconds by boiling, but stable to refrigeration and can remain in ice for 4 to 6 weeks. Drying and sunshine can kill the bacilli in few hours. It is susceptible to disinfectants such as cresol and bleaching powder, 6 milligram per liter. In general, biotype even TOR is more resistant than classical. Okay, so lab diagnosis and the halophilic infections will be covering in the next video. Like, share, subscribe. Thanks for watching.